melanoma is also a disease that can happen in children. And Dr. Brittani Seynnaeve is a pediatric oncologist at Children's Hospital, focusing on this specific question. So,
thank you so much for having me this morning. Thanks for the introduction. I am a pediatric oncologist at Children's at Pittsburgh, but I run our pediatric melanoma program and work closely with all of the other doctors and providers in the room. And I'm always so grateful to be included in the melanoma community. And thank you for taking the time to hear about this small percentage of patients that get melanoma, but are equally, if not more important. All right, so I will, I'm going to provide some background in pediatric melanoma. And thanks so much for that question earlier in Dr. Najjar's talk about the inclusion of uveal melanoma. That's pediatric melanomas up there, or I think it was actually mucosal, but with our ocular melanomas, mucosal melanoma, pediatric melanoma are all these really more rare subcategories that have been understudied and not included in as many of the trials. I'll tell you some about our UPMC pediatric melanoma program here today, and then we'll talk a little bit about the importance of research and improving outcomes for our children and adolescents with melanoma. As way of background, there are over 100,000 new cases of melanoma each year in the United States. The percentage of new melanoma cases by age group is shown here. So for the population that I care for the most, the 0 to 20 years of age patients, this makes up just a tiny, tiny amount of the overall cases of new melanoma. So about 400 cases per year in the United States. Becomes more common in our young adults, making up 5,000 of those 100,000 cases. But it is the second most common cancer in that young adolescent, early adult age group. And while this seems like a small number in the field of pediatric oncology, 400 cases a year is not insignificant. This is there are 16,000 cases of overall all cancer cases in children per year, and so 400 out of 16,000 is significant. And importantly, unlike the other skin cancers that are seen more frequently in adults, melanoma is our most common skin cancer in children, highlighting the importance to study this further. So how do we think about this? How do we classify melanoma when we see a child or a teenager with melanoma? We think about it in three buckets. Either they have what we call adult type or conventional melanoma, or they may have melanoma arising in a congenital nevus that they were born with or developed in the first year of life. And then last, there's a unique category, Spitz or spitzoid melanoma. It presents differently, it acts differently, and this predominates in the young population. Despite us being able to classify the different types of melanoma that we see, we know that these subgroups don't predict how a patient will do. And that's really tough whenever I'm having a conversation with one specific patient in the office. So we know that outcomes are generally better for adults, for children than adults. And we also know that our young children, so 0 to 10, typically do better than our older children and adolescents. But we still don't know exactly why or how to specifically pick out that subset of children who will have their melanoma behave more like an aggressive adult type melanoma. And that's a problem for us. And then this bucket that we see all of the time, the atypical melanocytic neoplasms. So they come to us as a long description after a biopsy, and with the punchline being, I don't know, we can't rule out melanoma, figure it out and decide how to treat the patient. But these are really particularly challenging and to date have been understudied. So how do we treat pediatric patients with melanoma? Well, the bottom line is that genuine uncertainty exists. It's humbling to come to these seminars and listen to all of my colleagues speak about all of the advancements that we've had for the treatment of melanoma. And certainly we employ those therapies in children almost because we have nothing else. And so, we do that somewhat blindly, and that's disheartening as a oncologist in pediatrics who relies on clinical trial data for most of our other pediatric cancers. And so even when it comes to how big of a surgery do they need, what do we do for these can't rule out melanoma cases? Should we do a sentinel lymph node biopsy? And if we do it, how will we interpret those results? Should we use systemic therapy? And then importantly, if we think we need to use systemic therapy, how do we get it for a child? How do we get it into them? Is it safe? Is it effective? Those are all questions that we have to ask. And so we are trying to catch up to our adult colleagues, but still there is a lot of uncertainty in the field. And importantly, prospective data is lacking. And how do we get that? It's all through clinical trials, as have been discussed here today. So just, thinking about new opportunities for treatment, I thought this really put into numbers the words that I'm emphasizing today. We have a website, clinicaltrials.gov. Anyone can go to it. It's a place where you can go and learn about clinical studies from around the world that may be open. We use this as treating physicians whenever we have a patient with a specific diagnosis to look and see if there's treatment opportunities that might not be available in Pittsburgh, but might be available somewhere else to get them to the best treatment. When I did this just a couple of days ago, it's so exciting to see that there's over 500 trials actively recruiting for melanoma as a diagnosis. When I refined the search criteria to include patients under 18 years of age, so of course the patients I take care of, only less than 5 treatment studies were included. And so, what are we doing to change this? So here in Pittsburgh, like I said, we have a specific pediatric melanoma program, and the question I answer every day is, why do you need a melanoma program? It's a common misconception, especially in the pediatric oncology world, that we just don't see it. We don't know where the patients are. We're assuming that someone else is taking care of them, or or it's just not happening. But I've already showed you that that's not true. And so again, melanoma is the primary skin cancer for pediatric patients. And although it's much, much, much more common in adults, we are so lucky to have a specialized center here at Hillman for melanoma. But in the past, our pediatric patients sometimes were referred there. Dr. Kirkwood used to see some of them, but really they were going to other children's hospitals. Families in our community were traveling really far distances to find someone to care for them. And oftentimes they were lost to follow-up and just not sure where to turn. And so the goals of our program are truly to provide excellent clinical care first and foremost. It's a goal to make sure all of our team members feel engaged in the process. This really is a team effort. This is not just me taking care of patients. To build our team up, and then of course to demonstrate research excellence and really be a national resource for patients and families with this diagnosis. So here in Pittsburgh, pediatric oncology, like myself, is a part of the larger cancer center. I physically am usually primarily located at the Children's Hospital, so the colorful hospital up the street. But I do work with my other melanoma adult colleagues down here at Hillman once a month, and I share program coordinators, and I'm a part of the overall melanoma research team. And so everyone in the room that takes care of patients as well knows that for everything that's presented today, they'll get an email from me afterwards or a phone call saying, hey, why can't we include kids in that? And I'll send them down the street, but let's expand the opportunities. I already reached out about the dietary intervention. Here's our patients, our providers. So I lead the program. Like I said, we have a dedicated pediatric dermatologist. Dr. Kirkwood's been instrumental to building this program over the years, and still is on speed dial for me for any questions that do come up. And then we have dedicated pediatric plastic surgeon and oncology surgeons who help take care of these patients as well. And where do the referrals come from? In my world, this is really unique. So of course, for a melanoma specific oncologists in the adult world, they work with dermatologists all the time. But for me, That's most of the time dermatology doesn't have to interact with an oncologist for most other cancer diagnoses. And like I said, these patients are oftentimes just at a loss as to where to go. And so we've studied this extensively. We've published this. I reach out to dermatologists and surgeons and pediatricians in the community, but the patients really do kind of get lost in the mix. They're not sure if they're supposed to go back to a dermatologist. Do they go to a surgeon? Do they go to our subspecialized surgeons at the Children's Hospital? They come from other children's hospitals around the country, and then luckily now we're getting more and more direct calls into our melanoma center. Again, I share a melanoma coordinator, and oftentimes we're getting second opinion requests from other physicians. And we do love to see kids. Yesterday, I saw a baby in clinic here at Hillman, and the staff loved it. The baby's doing well. All right. So here's our, just to share with you the progress that we've made over time. I joined Dr. Kirkwood when I was a trainee in 2015 to embark on melanoma research. At that time, the cases that we saw as a whole, whether it was at the adult or pediatric program of pediatric melanocytic tumors, was less than 5 per year. I was disheartened by that. And Dr. Kirkwood, I will never forget, told me that if I built a program, patients would come. And he was right. And so since that time, we've been receiving referrals on the order of about 30 to this year, likely over 40 new patients a year. We have a team that helps ensure that those patients are followed up and not lost to follow-up. And then as you can see, over the past couple of years, our program really has taken on a larger national reputation, and we're receiving a lot of referrals from patients all over the country, or second opinion requests from other physicians. So there's many bureaucratic obstacles just getting patients here from out of state, and we're working to get over those. But in the meantime, I will still always provide care for them and provide recommendations. And so lastly, I'll highlight the importance of research in improving outcomes, and really thank you to the patients and families that participate in this every day. And so here's a timeline. I thought I would show this and just talk a little bit about how it is so incredibly important that our clinical programs truly inform our research program. We cannot do this without patients and families. We can't improve the outcomes for other patients without the willingness to participate in studies from current patients. And so you can see, as I talked about before, in 2015, we launched the program. In 2017, I was no longer a trainee and came on as faculty. In 2019, we started initiatives to retain our patients and not lose them to follow-up. And in 2023, we started doing outside second opinion consults. And all along the way, the white bubbles are different awards and funding mechanisms that were provided to support the work that we're doing. And so when I'm seeing a patient in clinic, and we have one of my patients here, they know we'll talk about their clinical care and how school's going and everything that's important in their world. And then before they leave, I'm going to present the array of options that we have to study. To include them in studies and make progress for them and other patients. And so just a little bit about this here. One of our other foundations supported an award in 2022 to create a prospective registry for patients with pediatric melanocytic tumors. And so our prospective PEDS and AYA melanocytic tumor registry launched a year ago. This is open to all patients that we see, and is presented by our dedicated pediatric melanoma clinical research assistant. And this is really an effort to include these patients that have otherwise been excluded from many of the studies. So patients that have these unsure if this is melanoma or cannot rule out melanoma diagnoses, and those kids that have conventional adult type melanoma as well, but to follow them really for the long term. So we've enrolled 60 patients to date over the past year, which is exciting. This includes complete data, similarly to what was discussed before about collecting the data and how incredibly important that is for research. We include photographic data, which I can talk a little bit about. And then importantly, our patients and our parents complete surveys about the experience of living with this diagnosis and undergoing the treatments related to it. And we'll have long-term follow-up. I will mention one of the things that's particularly unique to the pediatric population is that when we're talking about even the surgical management of melanoma or melanocytic tumors, while it might seem less significant in a fully grown patient and a young child who still has growing to do, these surgeries can be a significant impact on their life and their growth and development. So doing a big surgery on a little baby on a growing arm can really impact their use and function and what they might be able to do or not do moving forward. And so families come in with a lot of questions about what's going to be the long-term consequences of the surgeries and what's it going to look like over time. And so we're paying, because of that feedback from patients and families, we're paying special attention to documenting how patients grow and develop into these surgeries to treat their tumors as time goes on. We are so excited. It's rare that a patient turns this down. And so we're hoping to be able to open this to other institutions and have submitted a request for funding to open this up across the country. And that's pending. But if we don't get that funding, we'll keep working until we can do that. And then I'll leave you a little bit. I'll talk a little bit about our first collaborative pediatric melanoma trial concept that we submitted through the Children's Oncology Group, which I'll tell you a little bit about. And so you've heard a lot about clinical trials today. In pediatric oncology, we function as a consortium under something called the Children's Oncology Group, or COG. This is the largest organization that's devoted exclusively to pediatric and adolescent cancer research. And it really is a unique collaborative effort. And so there's over 200 leading children's hospitals across the world that are included in this group, and over 90% of the 16,000 children that'll be diagnosed with cancer each year will be treated at a site that enrolls patients on these trials. And we love to tell our story in pediatric oncology about the importance of clinical trials, but we've really this group has made childhood cancer, which was virtually incurable decades ago, to one that all kids combined will have an over 80% survival rate. So we still have progress to make, but have come a really long way. And so it really is, as you can see, you need a lot of patients from these clinical trials, and with not a lot of patients with pediatric melanoma, the only way that we're really going to make a huge difference is to be able to work together. And so I've been singing this song to anyone that would listen for the past decade. And we're so excited to be working in this aspect now on a pediatric melanoma clinical trial. And so this was every year the Children's Oncology Group puts out a blueprint for research. What are we going to focus on this year? Never, ever, ever in the 50 years that the COG has been around has melanoma been studied within that within the consortium. And I finally got someone to listen. And in 2023, they agreed that this was a rare tumor that needed to be studied and will be a focus of upcoming efforts. And so we're working on that now. This is, there's been a lot of naysayers, as you can imagine. And so we spent some time in 2023 asking the people that care for these, so pediatric oncologists, adult oncologists, surgeons, and dermatologists and pediatric dermatologists, we sent surveys out to them, and we asked them to comment on what they do when they have these patients in their office. Who do they send them to? Would you be willing to send them to a pediatric oncologist if we could get them on a clinical trial? And we were able to report this out last year. And the bottom line is that we identified that these complex referral patterns are present. We live that every day in the clinic, but we were finally able to show that. But providers are still turning to pediatric oncology for help across all of these different subspecialties. Everyone was interested in helping participate in a clinical trial. And so we've used this to further strengthen our reserve to be able to study these patients specifically. Another exciting part of this process in getting the more national recognition for pediatric melanoma, there are many people who are working hard to try to be able to provide better recommendations to doctors in the office as to what to do with these patients. And so those people came together across multiple countries and finally with a common mission to work together. And we put together this report that's available in the literature, specifically looking at the evaluation and the management of pediatric melanocytic tumors. This was under support from the Children's Oncology Group as well, and we're using this background data to further support the development of a prospective clinical trial. And with that, I'll leave you with just the last piece of information that I will emphasize, that patient advocacy is so essential. We can't do this high quality clinical care and clinical research without hearing from you all, the patients. How are you feeling? Symptoms, and anything, and what we are doing is working for you. And so groups like AIM are so incredibly important to support this aspect. And so we always want to hear from you, the patients and families, and your voice is so important in this mission.
Yeah. Thank you, Brittani.
Thank you.
Good.
Thank you.
Yeah.